terminology, the word spirituality, the word religion, and what we came up with were characteristics to help us understand our terms. Then last week, we discussed the five universal spiritual needs and talked a little bit about philosophies of care and how those needs surface in patients. Today, we're going to talk specifically about assessment of spiritual needs and look at that from a couple of different angles. So to begin, let's start with a definition. I think your notes ask, the first question is something like, what is the minimum required? This definition, and you don't need to write the entire definition down, but this definition comes from an organization called the Joint Commission, or TJC. Is anybody in here familiar with that term? Or, okay, so I see some hands. So the Joint Commission, it used to be called JCAHO, the Joint Commission for the Accreditation of Hospital Organizations. The Joint Commission is an independent accrediting body, and they exist to help keep healthcare organizations accountable for the things that they say they're going to do. So we subscribe to their service. We pay them a pretty large sum of money so that they come in and make sure that our policies and practices follow the best practice standards, which they publish, and then they hold us accountable to make sure that we do the things that we say we're going to do. That is an important piece in modern day healthcare, because healthcare is no longer just available to everybody at your local hospital, your local community clinic, and it's just, there. Where you go to the place that's closest to you and you're going to get just the care you get. Healthcare has become a consumer product, and people go to certain places to get their surgeries and care because of the outcomes of those organizations. So people will get online. Some of you may be the kind of people who do this, or you have family, or know people who are like this. But they will get online. They're going to have a knee replacement surgery, and they'll look and see what is the mortality rate for this hospital I'm going to have surgery at. What is the infection rate for this hospital? What is the fall rate for this hospital? What is the chance that I'm going to have an adverse reaction after my surgery? What are my chances of having a good outcome if I have surgery at this hospital as opposed to a different one? And they look at all of that information, which is public knowledge, and they make their decision about where to go based on what they think their best chances are. So all of those things, those metrics that are measured within the hospital, make a difference in the care that we provide and who comes to our hospital to receive that care. So JCAHO is an important institution because it holds us accountable and helps maintain those standards. They have standards or best practices for every area of care within the hospital. What is on the screen is the spiritual category. So this is the best practice or the definition for spiritual care within a hospital organization. And they say, at a minimum, spiritual assessment should identify three things in a patient's life: their denomination, their beliefs, and the practices important to that patient. So at a minimum, those three things need to be identified by our staff. This information assists in determining the impact of spirituality, if any, on the care or services provided, and identifies if further assessment is needed. The standards also require the organization to define the content and scope of spiritual and other assessments, and to identify what qualifications are necessary for the individuals who perform the assessments. So at Baptist Health, who do you think, or where do we gather the information about spiritual needs in our patients? Where do we conduct spiritual assessments at Baptist Health? Anybody know or want to take a guess? Bedside, who's responsible? And that seems like an obvious choice, that the chaplain would be the person to come in and do that. We have close to 500 patients a day. I don't know exactly what the new admit rate is daily, and there's only about 8 or 10 chaplains, so that would be an enormous amount of work for that small group. Okay, the nurse, you all, you are going to be collecting, if you choose to work at a Baptist institution upon graduation, you will be the ones making sure that that information is collected. You're kind of the follow-up or backup, because there's a place that we do it first that usually catches everybody. Anybody know or have an idea? Admissions. That's right, whoever said that. So at Baptist Health, we have determined the best way to gather these 3 pieces of information is upon admission. If a patient comes in traditionally through the front doors, they go to our admissions area, they see an admissions representative, and they ask them a ton of questions, and in the middle of those questions are the questions about spiritual care. And they'll ask them those questions. There's 3 of them, I believe, on the in the electronic medical record. They include that, or they document that to that patient's chart in the electronic medical record, and then it's available for all the rest of the healthcare team while that patient is under our care, regardless of where they go in the hospital. In case the patient doesn't come in a traditional way, maybe they come in through the ER and it's a trauma, and you know, the need is to get them taken care of before we go in and find out if they've got insurance. Or they're a direct admit from one ICU to another ICU, then it becomes your responsibility as the nurse to come in and make sure that all that information is filled in and accurate. So not only will you be doing your history and physical, which is, you know, part of your normal protocol, you will make sure that those spiritual questions have been addressed and that that has been documented in the patient's chart. At that point, if the needs are greater than what you can provide, then you make a referral to the pastoral care department or to the chaplain. And the chaplain can come in and do a fuller, more thorough assessment. Doctors, oftentimes, after seeing the patient initially, will make a referral or a consult to pastoral care. And then that information is generated through our EPIC system, the electronic medical record, and it automatically sends that to the pastoral care office, and we get that information there. So, those are the basic needs, and that's how we do it at Baptist Health. Not all organizations do it that exact same way, but they have to have a plan, and they have to have a protocol in place to collect spiritual information. Let's talk for just a moment about the difference between assessing for any kind of need versus screening for needs. So not just spiritual needs. We might be talking about emotional needs or physical needs whenever you do that history and physical. What do you think the difference is between those 2 terms? What's the difference in screening for a patient's needs and assessing patient needs? Anybody?
Assessing is more thorough.
Okay. Assessment is going to take more time and more thorough.
Assessment, I think, is going to be on an individual person, and screening might be for a group of people.
That's possible, depending on the amount of people that come in. But generally speaking, when you see a patient initially, you're just going to do a cursory, okay, I don't see blood or bones. Let's see, where does this patient need to go to get a fuller assessment? What are the needs this patient has? And then you funnel them to wherever they need to go. And then at that point, more time and energy is spent assessing what is really going on with the patient in order to find out how to provide care. So spiritually speaking, screening for spiritual needs is a lot like doing that initial triage that you would see in an emergency care situation, or if you have like mass casualties, where you want to just do a cursory, what are your needs? What's going on? Let me find out what's happening so I know what direction to point you to get the kind of care that you need. Because a patient who is crying hysterically could be crying hysterically for a lot of different reasons. Maybe they've just got some terribly bad news and they're having a normal reaction. Maybe they're depressed and out of their, they're chronically depressed and they're out of their medication. And so they need to be sent to someone who can talk to them about that. So we screen for spiritual needs kind of like we do when we go in and assess overall what's physically going on. Because the main purpose in screening is to hit the things that are the most obvious and to stop the bleeding, so to speak. We want to deal with the presenting problems before we delve into what's really going on, what's the problem here. Because whenever a patient comes in, especially in an emergency situation, and they do have bones sticking out and blood gushing, what are we as healthcare providers going to do first? We're going to stop the bleeding. We're going to put compression on that wound. We're going to get the bones set. And then we'll start asking questions. Why did this happen? What's going on? And discover, try to figure out what needs to take place to care for them. A third characteristic here is that in contrast to screening, assessments take a longer period of time and are more involved, which we already had identified for us. So our screening is something that is usually quick and cursory and very much like triage. But spiritual assessments take longer because the purpose of doing an assessment is to find the root causes. You do want to know what is happening, what is going on with your patient. And what the cause of that is so that you can treat the cause and not just the symptoms. So there's a difference between screening and assessing. Both of those are skills that you need and that you will develop in order to be able to manage large amounts of patients at one time and to give them good quality care. All right, is everybody good with that screen? Not yet? So the next thing I want to say about spiritual assessments is that they are a process. There's a gentleman named Bruce Rumbold who says spiritual assessments must be a process, not merely an event. And the reason is because it sometimes takes time for emergent insights to surface, and sometimes individuals need a little while to warm up before they want to start exploring what's really going on in their hearts and minds. And if somebody doesn't want to talk about the deep issues in their lives, we can't make them talk about those deep issues. We wouldn't want anybody to treat us that way and to force us to talk about things that are personal and private. We have to develop and build a relationship with our patients in order for them to feel that comfortable sharing those things with us. So it's a process. In particular, spiritual assessments are a process. So they are ongoing. They rarely evolve they're ongoing and evolve over time. Rarely are they effective in a one-time setting. I've done a lot of spiritual assessments, and I've done them in emergency situations. Sometimes those work out pretty well, and sometimes they don't. And sometimes it takes the whole team, the nurse, the doctor, the chaplain, the social worker, other members of the team, talking and coming in and out, and then communicating and trying to figure out, putting all the pieces together to get a good image of what is going on with that particular patient. So we know that assessing and screening are different from one another, and that assessment takes longer. Why do we need to do these? What is the importance in conducting spiritual assessments? Number one, it helps us develop trust with our patients. Spiritual assessments help us develop trust. That's what will aid in a patient being willing to pursue the deep issues in their hearts and minds. If they feel like they can trust us, then they'll be more open and willing to open up. Number two, it helps to avoid conflict. On our first day of class, the lecture about our terminology, one of the main points I tried to get across was we can all use the same words, but they mean different things. And when that happens, sometimes conflict occurs, misunderstandings occur. Doing spiritual assessments helps to keep us from having those conflicts, because it's during that time that we're making sure we're using the words that we are all using mean the same thing. And we're working to understand what the patient is saying. The third thing that it helps us with is to understand the patient's state of mind. So a spiritual assessment helps us develop trust with our patients, helps us to avoid conflict with them, and helps us to understand where they're coming from, how important their spirituality is, if spirituality is important to them at all, what their thoughts are about life and death, and their philosophy of all those things. It also helps us as practitioners evaluate negative presuppositions. That's kind of a fancy way of saying something very simple. Anybody have an idea what a negative presupposition is? What you think that means? Say that again? Wrongly assuming something. It's like stereotyping people. It's a mindset or a belief that we have developed throughout our lives because of the way we are socialized. And our upbringings, the way we were raised, the areas of the country that we're raised in, cause all of us to have negative presuppositions. A good example, I'm not trying to be offensive, if you involve, or this is an activity that you're involved in, but it's a really good example culturally of how we have kind of overcome things. But smoking used to be, back in the 40s, considered really cool and really hip. And then we found out that smoking's bad for you. And then smoking became like the worst thing you could do. So in the era that I was growing up, smoking was really negative. And I was told, you don't smoke, we don't smoke, no, smoking's not good for you, smoking's bad for you, nobody in this family's going to smoke, smoking's not a good thing. So I grew up hearing all the negative messages. I grew up in a time period where commercials used to encourage smoking and then went away and saw the transformation in the media away from smoking. Used to, there were billboards that touted all kinds of different cigarette products. You don't see that stuff anymore. And on the cigarette packages, you see the Surgeon General's warning that this could cause cancer and other bad diseases. So culturally and individually, we have looked at smoking as a bad thing. What that does, in reality, is when I and people that have been raised in that kind of environment, when we see people who are smoking, I have those immediate negative images come to my mind because that's what I've heard all my life. So I have to identify, just because they're smoking doesn't mean they're a bad person. Just because they have tattoos doesn't mean they're a bad person. Just because they have whatever doesn't mean they're a bad person. We all have those. They're different for each one of us, but we all have them. They're prejudices, they're stereotypes, and it can be based on your hair color, it can be based on your body size, it can be based on all kinds of things. Doing spiritual assessments helps us overcome those so that we get to know the real person and we don't make external judgments or snap judgments based on appearance. All right, the fifth thing there to help us, and the reason why we conduct these assessments, is in order to discover positive support systems for our patients. We want to know, do they have family? Do they have friends like family? Do they have a church home? Do they have a social group that's like family to them? What are the positive things in their life that are going to nurture and support them spiritually that we can make sure that they stay connected to? And then these last two go together pretty well. We also conduct spiritual assessments in the clinical setting so that we can make sure our patients have an aftercare system and we help them make plans for the future. We would never think to send a patient who has had bypass surgery, still hooked up to an IV, out the front door and discharge them and say, okay, hope you do well with that. If you have any problems, let us know. We would never think about doing that kind of thing. We want to make sure, okay, we got to get all that stuff out of them. We got to make sure they've got follow-up appointments to their cardiologist. We got to make sure they got their medications before they leave the hospital. There's all these things we need to do to make sure that they are healthy when they leave and they don't have to come right back. The same thing is true if we have patients with deep spiritual needs. We don't want to send them out the door saying, yeah, I know you're depressed and on the suicide watch. I hope you get over that. Instead, we want to say, here are some resources. Here are some things that you can do, some people you can call, support groups that are available, places in your area where you can get help. So we do that to make sure that their continuum of care goes on all the way through discharge and even after they leave us. Okay, this is a good place to take a little break. When we come back, we'll talk about some elements. But 10 minutes, so about 7, 8 minutes after the hour, we'll pick back up. If you came in late, come on up and let me get you an assessment and assignment sheet. Time for us to reconvene. So let me give you these next two slides quickly. This is not in your notes, but these are examples of the types of questions that would be asked during a full and thorough spiritual assessment. And these come from the Joint Commission, or TJC. So it's just sample or examples to give you an idea about the kinds of things that we're asking. What or who provides the patient with strength and hope? What role does prayer play in the patient's life? Do they want it? Do they not? How do they express their spirituality? What would they describe their philosophy of life to be like? That's an important piece, especially when you start dealing with end-of-life issues. What type of religious or spiritual support does the patient want? Always ask, what do they want from us? How can we help them that will best meet their needs? And then find out, do they have a clergy member that is important or special to them that they would want contacted? In case you're not familiar, there are some terms on this slide identifying different clergy people from different religions. So we're pretty familiar, the term clergy is like the big umbrella term. Clergy covers almost all faiths, religions, denominations, and groups like that. We're pretty familiar in this part of the world with the term minister and chaplain. We use those in the Christian faith quite a bit. So you will either have clergy that are titled as a minister of something, or they will be the pastor, senior pastor, discipleship pastor, senior adult pastor, those kinds of things. So we're pretty familiar with that. The term chaplain is more of an ecumenical term, and it's used in the context of hospitals. Y'all are all familiar with having hospital chaplains. Also in the military, anybody has military experience, you know they have chaplains available to assist the servicemen and women. It's also used in business. There are corporate chaplains that work throughout the business community, especially in large urban cities, to help minister to people who are working a lot, those people who work 70, 80 hours a week. So chaplain is an ecumenical term, and it covers over all types of faith beliefs. It doesn't try to assimilate all of them together and say, we're going to, take the best of everybody. But a chaplain is one who will cross over and deal with the different beliefs of different faith groups. So the term ecumenical helps describe that. What that word means is it covers all different kinds of groups. Doesn't assimilate, doesn't just focus on one, but tries to minister across the different belief systems. Then the term imam is one that you may or may not be familiar with. That is a Muslim cleric. And the last one is rabbi. And that one is the term for a Jewish cleric. So we've got the terms for within the Christian faith, the Jewish, and the Muslim faith up there, just to make sure that you knew what those terms meant. Also, we want to ask our patients what dying means to them and the role that their church or synagogue plays in their life. Also, what is it that keeps them going? That's hearkening back to that universal spiritual need of hope. And then lastly, how has the illness affected their family? Whenever a individual is chronically ill or has a tragic or terminal condition, it doesn't just affect the family, the patient. It affects their entire family. And for those of you in here who have had that experience where you had a loved one that was terminally ill and maybe your family brought them into your home to care for them, or maybe your family had to rearrange your schedule so you could always be at the hospital. When terminal or tragic or chronic illness strikes a individual's life, it affects their whole family. Because if you bring grandma in to stay at your house so that your mom and dad can take care of him or her, grandparents, then you are rearranging your entire schedule. Your needs don't become the most important needs anymore. Now it's your grandparents' needs. We got to work around their medication schedule. We got to make sure that if something happens, they get taken care of first. Their sleep schedule is more important than our sleep schedule. So it totally affects your family's life. If they're in the hospital, you will find, if you work in a hospital, that when tragic, critical care type illnesses occur, families will essentially set up camp in the waiting rooms. And they will stay there 10 or 12 hours a day for weeks on end, sometimes months. So they can be right there where their loved one is and be available to go in and out. That's a total rearrangement of a person and family's life if they're spending all their time at the hospital. You can't do anything at home. It's hard to keep a home up and be at the hospital all day long. So illness affects the entire family, and those are important things to talk about when we're doing spiritual assessments. When we get started doing them, here's some preliminary concerns. I hope this piece right here will be very practical for you and very helpful when you start doing it yourself. Number one, as in everything that you will be taught here at Baptist Health College, spiritual assessments need to be patient-centered. We need to focus on the needs of our patients. What our beliefs and thoughts are irrelevant. In the clinical setting, it's what the patient's needs and thoughts are that are the most important. Secondly, they need to be easy to conduct. If you're going to do something formal like we did at the beginning of class, it needs to be easy. If you're just going to do something verbal, it still needs to be easy. Because in the clinical setting, you don't always have the time and opportunity to sit down and do long, involved assessments. The third thing to remember and to be concerned about as you enter into doing these is to stay free from what is called sectarianism. Another big fancy word. Anybody got an idea what that means? Ever heard it before? If you've paid attention to the news in recent years, you've probably heard the term sect in relation to the Muslim faith, where we